Hello. Hello.
Hello.
Oh, is that Ahmed?
Yeah, it's me. Hi.
Great. So you can hear me?
Yeah, I can.
That's excellent. Fine.
Okay.
I shall mute. I just wanted to test the system before you got going.
It's perfect, and I can get a video. I will start my video as well. But yeah, it's perfect video, and it's
Oh, great.
Hi.
Hello. Nice to meet you.
Yeah, the pleasure is mine. Actually, I'm really so grateful to have you.
Not at all. So yeah, hopefully everything's going to work okay. We've got some building work going on in the background, but they usually quieten down in the afternoon. So I've got my headset, so hopefully you'll hear me okay.
Yeah, for me the voice is really perfect. So it's
Perfect.
Okay.
Good.
I hope mine is okay too.
Yeah, absolutely fine. So
Okay.
I will stay in the background and listen carefully for the first two talks. And I don't know how you guys do it, whether you want us to turn videos off whilst we're just listening.
Actually, the first two talk, I made them very quick because I want to actually enjoy your talk. It's the main scientific talk for today.
Okay.
So that's why we're gonna do it really fast. And I think we're gonna enjoy the question and answer session because actually my colleagues and even myself even were having a lot of questions regarding the fast forward because this is the next step in our practice. So I hope we're gonna get some useful and informative information, and we're gonna actually I should expect that we're gonna ask for help soon in conducting our own study, hopefully.
Okay.
Yeah,
sounds good.
Would be
very exciting.
Yeah, it's for me actually. Yeah, you need to make sure that all the settings are fine. We're going live. Okay, we have to wait just for a few minutes, like 3-4 minutes until it's for our time. Which
absolutely fine. Yeah.
Can go.
And then how do you do Q&A? Do people write in the chat or?
They're gonna write it. Yes, they're gonna write it because actually we got so many registration. Actually, not everyone is here yet, but we're expecting a lot of attendees. So I think it's gonna be much more better if we can if we can use the texting. It would be much
fine.
Yeah, and we're gonna postpone all the questions till the question answers. Yeah, exactly.
Cool. Great.
I have a lot of duties. I'm the moderator beside being a speaker, so it's a lot of responsibility.
Yeah, these meetings are funny, aren't they? It's yeah.
Yes,
it's quite stressful doing chairing Teams meetings and trying to keep on all the hands and the chat and
exactly.
And not to mention all the WhatsApp conversations going on in the background. Can't monitor those.
Yeah, that's true. Dr. Radwa, I just want to make sure that you're with us. Can you unmute and just say anything? Hello? Dr. Radwa, can you hear me? Okay, just 1 minute. We'll check if Dr. Radwa having any problem with the connection, and then we can start directly. مش عارف شغال ازاي. اصلا دي وايرلس اعتقد. مش لازم تتعرف على انا ما اعرفش ده في البلوتوث ده ولا ايه. في بلوتوث. Perfect. Dr. Radwa, can you hear me? Just I want to check for your sound if it's of a good quality. Dr. Radwa, can you hear me?
Yes, Dr. Ahmed.
Okay, perfect. Okay, so you can mute again, Radu, so that we can start. Okay, perfect. دي فيها مايك. Okay, so if you're following, I think we can start now our webinar. Just a quick sound check before starting. So just in the chat, I just want confirmation from any of the attendees that you're listening and everything is going fine with you. Okay, that's perfect. So you're following. Okay, so first of all, I would like to welcome you all for our Bahia Hospital Radiation Oncology Department webinar. Actually, it has been a tough year. Last year, it was, you know, we were missing the in-person meetings, and there was very insufficient scientific activities, but actually everyone knows why. So it's really a great pleasure meeting you all again today. It's and I hope this year's we're gonna have so much more activities, and we're gonna have meets more and more, hopefully. So for today, we're having a very, very special guest. Actually, I'm sure many of you are familiar with her name and with her, actually. Dr. Anna Kirby. Dr. Anna Kirby is a clinical oncology professor at the Royal Marsden, Sutton, UK. She's also the president-elect of the European Society of Radiation and Oncology. It's a great pleasure having her with us today. She's going to be the main speaker for today, so I'm not going to waste so much time in the introduction, but she's actually one of the most eminent oncologists in the field of the breast irradiation. So actually, we've been waiting for this same webinar so much. I'm sure it's going to be so informative and so full of information for all of us. I've also my colleague and friend, Dr. Radwa Hamdi. Dr. Radwa is consultant of oncology at the Cairo University, and she is also a consultant at Bahia Hospital. So I would also want to welcome Radwa with us. Before starting, I would like to thank you all who joined our webinar for today, and to thank also all my colleagues who worked on the participation, the digital team and the IT team. Thank you very much. And actually, your effort was of a benefit, because here we are now with our colleagues. We are together, and actually, I hope this webinar is going to be really indicative for all of us. Okay, so actually, I have to introduce myself as well before starting my presentation. So I'm Dr. Ahmed Amin. I'm a consultant of radiation oncology, and I'm the head of the radiation oncology department at the Bahia Foundation for breast cancer, for early detection and treatment of breast cancer. So I want to share my screen now with you to start our presentation. Okay, I hope you can see the presentation. Oops. Okay, so I just want to check the chat to make sure that you're following my presentation.
It's all good, Ahmed.
Yeah, okay, perfect. We can see it. Okay. So I'm going to start with the first presentation. It's going to be a very short presentation, but since we're not meeting so regularly, so I'm going to give you like a quick feedback about what we were doing in the last year, in the COVID year. So I'm going to discuss the department's annual statistics during the year of COVID-19 pandemic. Actually, we're all living in the same world. So actually, we all had this pandemic. It wasn't regional. So we all suffered. Our all practice was affected, and all of us, like many people, it happened like once at a sudden. So everyone had his or her practice change. All the department like applied some emergency plan in order to keep treating our patients. So these are our statistics for the last few years. And as you can see, the number of patients which were treated in the department was not affected by the COVID. And I was so glad when I was preparing those slides from our database. And I want, after reviewing this slide, I just want to send my very thanks to my team, actually, and all who was working in the hospital, because actually we didn't stop treating our patients even for one day. Even through the lockdown, we were just doing our job. So I was really glad when I was reviewing this curve. But if we want to see 2021 in depth, we can see that, I'll just use a pointer. Okay. We can see that we had a drop in, this was the beginning of the COVID in Egypt. We had a drop. Of course, we were trying, in the beginning, it was a very vague pandemic for all of us. So we were, trying to ask our patient to delay their treatment. And that's why this drop, we can see this drop, as actually by the end of the year, we are now almost at the same levels and even more, because we're like compensating for the period where no treatment was given or minimal treatment was given. If we want to see the comparison between the radical and palliative, it's almost the same percentage or the same ratio, but we can see that actually in the beginning of the pandemic, most of the cases were palliative cases, and this can be explained. It's easy to explain it because palliative patients cannot wait for their treatment. They need it for pain relief or cord compression, but patients who are treating radical treatment they waited for a while, and then we are treating with the same ratios again. Of course, as any department in the world, we had our emergency plan, and the emergency plan depended on omitting any treatment with low benefits and minimizing hospital visits. So we omitted radiation for some patients with DCIC, the patients with favorable prognosis and low risk for recurrence, the low and intermediate grade, size less than 4 centimeters, surgical margin more than 3 millimeter. And for invasive tumor, the patient who had modified mastectomy, we omitted the radiation. Actually, for T1, T2, and 0, they are already not indicated, but for T1, we were omitting radiation for them. And for conservative breast surgery, we omitted radiation for favorable disease patients who were older than 65 years with tumor less than 3 centimeter and and on tamoxifen treatment. And actually, we're supported by strong publication that were supporting our practice. And actually, we used the Lancet publication because we used the same criteria. Actually, tumor 3 centimeter tumors and negative axillary nodes, actually we were also adopting this management. Okay, so the patient for whom the radiation was omitted, 27 patients with DCIS, 17 patients with mastectomy, but actually this number needs to be revised because those are the patients who were referred to our department for consultation regarding radiotherapy, but actually some patients, they might be managed in the surgery department and they had a T1, for example, N0 disease, and had a mastectomy, so they didn't send it from the beginning. delivering. But actually, when I'm talking about 17 patients, I'm talking about N1 patients. So those are the patients who referred for radiation consultation, but we prefer to defer radiation for them. And for conservative breast surgery, 32 patients were referred to us for radical radiotherapy to the breast, and we kept them under follow-up. And actually, the good news is that all of those patients are locally free so far. But actually, it's just a 6 months follow-up, so we're expecting further, longer follow-up, and I hope they're going to be safe. Okay, and to minimize our hospital visits, we were adopting the single fraction palliative radiotherapy, and most of our patients actually receive a single fraction. But those patients who received multiple fraction were the patients who were receiving a bigger volume or some other brain lesions, for example. And for the oligometastatic patient, we have two protocols, one of them over 3 fractions and the other over 5 fractions, but we stopped the 5 fraction protocol, and all of the patients were receiving the treatment over just 3 fractions. And regarding the breast radiotherapy, we offered our patient the simultaneous integrated boost for the whole patient. So instead of delivering the treatment over 4 weeks, 3 weeks for the breast and 1 week for the boost, we were delivering the treatment over just 3 weeks. And actually, for the breast, we all know that the standard treatment is delivered over 3 weeks. This is the standard hyperfractionation, and this is our practice at Bahia. But actually, the landmark change in our practice was starting our FAST protocol. Our FAST protocol, you can see it from here, that this is the sessions were supposed to be delivered to the patient. It's 15 visit to the hospital, which, and we all know that those 15 visits mean 15 days outside the home with risk of getting infection with COVID. So minimizing those to just 5 fraction with a week apart between them was the landmark in the change of our practice. And actually, Dr. Rod was going to tell you much more details about this change in practice in details in her presentation. So actually, when we started this protocol, we were a bit worried because in general, we deliver 2.67 grays per fraction, but we were delivering even more than double the standard radiation which we used to. And actually, if any of you was practicing from even more than 10 years or 15 years. Actually, before that, we were even using 2 grays and 1.8 grays. So with 5.7 grays, we were so skeptical and worried. But actually, our worries vanished when a very important trial was published from the UK. And it was about the safe 10-year result and regarding this treatment and proving that it's safe and it's equivalent to the other treatment. So we were starting to practice with much better comfort. And actually, it was all new. It wasn't in the guidelines, but when I was preparing this presentation, this slide actually I added just today. And it's nice for me that this was added soon, that even the NCCN, they added the FAST regimen for some selected patients when multiple visits to the hospital are not favored. So that was added recently. And I believe that this might be the practice in the future. There's even more aggressive regimens. I'm sure that Dr. Anna is going to give us more and more advanced regimens about that, regarding that. But actually, for us, we were skeptical about the 5.7 weekly fraction, but now they are considering 5.7 daily fraction. So I think her presentation is going to be really interesting, and we should know what's this more aggressive treatment is hiding for us. So that's all. Thank you very much, and that was my quick presentation. So we can actually move to our next presenter, Dr. Radwa Hamdi. Dr. Radwa Hamdi, consultant of radiotherapy at Bahia Hospital. Actually, she's going to get into more details about our FAST protocol, and she's going to give you a quick overview about what we was doing with our patient during the last year. Actually, Dr. Radwa, you might share your screen now.
Okay. Thanks, Dr. Ahmed. Let me share my presentation.
You can share it now, Radwa, actually. You can just add the share screen.
Okay.
Actually, we can see your screen, Radwa. So please, yes, okay. It's fine now. Yeah, perfect. Yeah, perfect.
Okay, let me start. Thanks, Dr. Ahmed, and thanks for all Bahia team to be with you today and sharing with Dr. Anna our experience in FAST protocol. As Dr. Ahmed said, that COVID event have changed a lot of medical practice all over the world. And we have to go with to treat our patients and to have not to stop any treatment, as we are proud that we didn't stop even one day treating our patients at Bahia Hospital.
Dr. Radwa, I'm sorry for interruption, but can you maximize the screen? Can you
okay,
just make it a full screen presentation? Show view, you need to make a show view. Yes, perfect, thank you.
Sorry, I have a little internet interruption. So we started phase 2 trial evaluating weekly hypofractionated breast radiotherapy, as this experience wasn't known at Egypt before, or a little scale. So as Dr. Ahmed mentioned, we decided to divide our patient at COVID pandemic to 3 groups. I will talk about the group P today in FAST radiation protocol. So we divided our patients into 3 groups, Group A and Group B and Group C. Group B, who are eligible for FAST radiation protocol, the dose was 28.5 over 5 fractions over 5 weeks. So the eligibility criteria, we included some criteria so we can start our treatment. Ductal carcinoma in situ, low and intermediate grade, more than 5 centimeter, or surgical margin less than 3 millimeter. Patient with ductal carcinoma in situ, high grade or invasive tumor, modified radical mastectomy, T1 to T3, N2 to 3, and all the conservative breast surgery were included in our protocol. Reconstruction are accepted except patient with silicone implants. We excluded some criteria for from our trial. Bilateral breast cancer were excluded. IMC radiation. IMC irradiation not included in our protocol regularly, except if they are IMC positive patients. Pendulous breast and silicone implant were excluded. So post indication, we have some criteria for indication for the for boost indication regarding the ratio for the boost and a whole breast. So we include the whole for boost less than 1 to 3. So we can include them in fast trial with separate 1 week 5.7 gray per 1 fraction. And also some pathological criteria included: patients less than 50 or patient more than 50 with high grade or surgical margin less than 2 millimeter. Otherwise, no boosts are indicated or included in our trial. Some fast consideration are included as axillary lymph node, all axillary lymph node or sentinel lymph node reconstruction are allowed, except, as I said or mentioned before, that silicone implants are refused from our protocol. 3 weeks or more after chemotherapy or surgery, electron beam for boost is allowed. Also, high photon and gating is allowed. So our dose is 28.5 gray over 5 fractions over 5 weeks, selected weekly. We started to contour our patients and to go for the constraints. As the constraints we accept for the plans for the PTV eval for the whole breast, V90 is more than 90%, V105 is less than or equal 5%, and V17 is less than or equal 2%. For the boost, V90 is more than 90%, and V105 is less than or equal 5%. For the ipsilateral lung, we accept for that V30 is less or from the range 15 to 20%, and V15 from 30 to 35%, and V5 50 to 55%. For the contralateral lung, the V5 is less than or equal 5%. For the heart, V5 from 30 to 35%, and V25 is less than or equal 5%. For the contralateral breast, we accept for the V30% less than or equal 5%. So my main talk will be for the preliminary data for the acute toxicity for our patients. As we started from 1 year, we just assess the acute toxicity for not more than 10 months still now, according to the common terminology criteria for the adverse event. For after 1 month and 3 months and 6 months, we assess our patients. The trial progress was from March 221. So all the patient recruitment we have 402 patients. Regarding the mastectomy, we have 127 patients. Regarding the conservative, the patients underwent conservative breast surgery, 305 patients. For the mastectomy patients, we have 26 patients underwent immediate reconstructions. 95 have no reconstruction yet. And so for the mastectomy patients, 95 of the patients from 127 were included in our protocol, and 32 patients excluded as they didn't meet organ at risk criteria or the constraint. So we exclude them and give them hypofractionation regimen 40 gray over 15 as a convention. For the conservative breast surgery patients, we have 305 patients included in our study, 278 patients. We have, for the boost irradiation, 160, 80 patients, and no boost irradiation, 190. Maybe for didn't meet the criteria or no boost irradiation for them. For the target volume irradiation, in the mastectomy patients, 95 patients have 13 patients we irradiate chest wall, and 63 patients chest wall and supraclav, and 19 patients we irradiate chest wall and supraclav and axilla. For the conservative breast surgery, which include 287 patients For breast, only 169, and breast and supraclav, 91 patients. Just we include 1 patient in prone position in our study, not more than one patient. So for the toxicity, we have 382 patients, 65 still on treatment, 47 yet the toxicity not assessed yet, and the toxicity assessed in 270 patients. This is a chart for preliminary data for the skin and subcutaneous toxicity. We have from the 270 patients, 204 patients passed very smoothly with no skin reactions, and they are very fine. 38 patients have grade 1 reaction, 23 patients have grade 2, and 5 patients have grade 3 reaction. For the arm lymphedema, 230 patients, no lymphedema yet. And for grade 1 arm lymphedema, we have 33 patients, and for grade 2 lymphedema, we have 5 patients. 0 patients for grade 3. 2 patients not yet assessed for the arm circumference, so we didn't assess yet. There are 270 patients, so these are 268 patients. For the arm lymphedema also, we the blue chart show the axilla excluded, and here these bar charts show all the axilla were excluded, and this chart show where the axilla we included. So we have 201 patients with no lymphedema who have axilla excluded, and 19 patients with grade 1 lymphedema, and 2 patients with grade 2 arm lymphedema. Those patients who have axilla included in our plan, as I mentioned before, we have some patients of a mastectomy, chest wall and chest supraclav, or chest wall and supraclav with axilla irradiation. We have 29 patients, no lymphedema, 14 patients with grade 1 arm lymphedema, and 3 patients with grade 2 lymphedema. As I will present for you a case with reactions. So we have Dr. Anna experience to mention for us to help us to see our patients and to explain for us. We have in this trial different demographic data and different patients from different countries. As you know, the Egyptian patients are much obese and have a large breast volume if we compare them to European patients or other patients. So we have Mrs. A.M., 49 years old female patient. She was diabetic and hypertensive smoker. Our patient was diagnosed as perimenopausal breast cancer. The mammo showed dry breast cancer mass 9 o'clock for histopathological confirmation by RAD5 axillary indeterminate lymph node. So we have true cut biopsy from the invasive showed invasive duct carcinoma grade 1. Fine needle was taken from left axilla and show reactive hyperplasia, negative for malignancy. The MDT decided that this patient will underwent right wide local excision and sentinel lymph node with mammoplasty. Remember, we said that we exclude any reconstruction. We exclude the silicone reconstruction, but any reconstruction is accepted. So the patient underwent right wide local excision with sentinel lymph node with mammoplasty only, no reconstruction as is conservative. I said that for just to mention that a modified radical patient may have some reconstruction. So the patient was T2, pathological T2 and 0/3, sentinel lymph node, ERPR positive, luminal A, HER2 negative, and Ki67 18%. The patient started her adjuvant chemotherapy TC4 cycles in the 13 February 2020, then referred to us for post-operative She met all the inclusion criteria I mentioned before, so we decided to include our patient in our study. She received 28.5 gray fast protocol from 14 May till 11 June, but the patient unfortunately experienced very severe skin reaction, grade 3, and the patient now has severe fibrosis and induration for the breast in follow-up. I will show some. This is from the planning system. Although the patient was met all the inclusion criteria and all the acceptance criteria we put for the patients, but let me show you the shape of her breast. She has severe fibrosis and severe induration now. Right now, this is the shape after this is the shape of her breast actually after 6 months follow-up, maybe at the 8 months follow-up. So our management, we started topical steroids and systemic steroids, but with little bit response. So we decided to send her for hyperbaric oxygen, waiting for the results. If she is not improving, we may have to consult our surgeon for mastectomy. Thanks.
Thank you so much, Dr. Radwa, for your presentation and for the case. It was really interesting, and for sure I'm familiar with the case. So, but actually this is a rare case that we wanted to share our experience with our colleagues. Actually, most of the patients just go through the treatment without any complication, even without any skin reaction. But this is a rare, interesting case, and hopefully she's going to get better soon. Okay, and now for the main speaker for today, Dr. Anna Kirby. Dr. Anna, you might share your screen now and start the presentation.
Right. So it says host as disabled participant screen sharing. Screen. How are we doing? Can you see it?
Yeah, it's working. Yeah, it's perfect like that.
Right.
Perfect.
Let's start show. Good. Can you see it full screen now, Ahmed?
Yeah, it's perfect. Yeah, you can proceed, Dr. Anna. Thank you.
Excellent. Well, thank you very much for inviting me to speak with you this afternoon. And although there are obviously many negative aspects of living through a pandemic, one of the loveliest things is that we can connect in this way and share our practice without anyone having to fly anywhere, which is lovely. So it's great to be with you all, and really fantastic to hear your experience. And actually, there are many areas where your practice flow absolutely matches what happened with us here in London. So we had that dip April, May last year, and then it's picked up. But I agree with you, the ability to have kept treating patients every day through this pandemic has been a real privilege. And this trial, the results of which I'm going to present to you now, was really a game changer for us in the UK, in the way that I guess the FAST trial was for you, or has been for you. So it'll be great to discuss further. So in this talk, what I'm going to do is run through the FAST-4 trial data. And then I've just got some discussion towards the end about sort of how we've gone about implementing findings, discussion points, national consensus, etc., and our story through the pandemic. So I know we've got a little bit of time for questions at the end. So hopefully I won't eat into that too much. So this data, I'm sure many of you will have pored over this paper in detail. This is work that was led by Murray Brunt, one of my colleagues working up in the north of the UK. And I've underlined also Joe Haviland, who's our chief statistician on this study, and it's really thanks to Murray and Joe. I know they had very many late nights at the end of March and throughout April getting this data out and into print, and they really felt that was the best way to get the message out in time to help people during the pandemic. And here's the abstract page, which has got the details there in case you wanted to download it. So yeah, Lancet 2020, volume 395. So if I start with the aim of the study, so this was to test a 1 week course, so 5 fractions over 1 week, not the 5 weeks as used in the FAST trial. And this was curative whole breast radiotherapy and chest wall, as I come on to, and comparing this against our standard at the time, which was the 40 Gray in 15 fractions over 3 week schedule, with a primary endpoint of local control and secondary endpoints looking at late effects. And here's the trial design. So patients with T stage of 1 to 3 could go in, N 0 to 1, and of course they needed to be non-metastatic. And the randomization was of 4,000 patients to 3 arms, the standard arm that I've already mentioned. And then you can see this has got the hallmarks of a John Yarnold designed study, in that he nearly always recommends going for these 2 test arms in order to derive some more explanatory data about alpha beta ratios and inform our future trial design. So he went for these 2 arms, 26 Gray in 5 fractions versus 27 in 5, with the hope of being able to discern some equivalence of these doses to smaller fraction size regimens. And patients in this trial had their radiotherapy according to one of these randomized regimens, and they could have a boost, and centers needed to define upfront whether they were going to treat all of their patients going into fast forward with the 16 and 8 Gray fractionation, which was the standard at that time, or this lower dose boost of 10 in 5. And for our center, we opted for 16 and 8. And then patients had annual clinical assessment, and they are still going through that up to the 10-year time point. And they have clinical photographs at 2, 5, and 10 years, and then patient-reported outcome measures tested at more frequent time points early on, and then at 2, 5, and 10 years. Primary endpoint, as I said on the last slide, ipsilateral breast tumour relapse, with the usual array of secondary endpoints. And the median follow-up at the time of analysis was 6 years. So this was a big old study, and I'm not going to go through the sample size slide in detail. I should have said that most of these slides come from a master data set which Joe Haviland has put together, and the Fast Forward team are really collaborative, and let those of us who are giving talks of this nature dip in and add to the slide set so we've got a growing body of slides. But just the bottom line was that this was a non-inferiority study, and it assumed a 5-year local recurrence rate of 2% in the control arm. And it was thought that the results would be regarded as non-inferior if the absolute increase in 5-year local recurrence for the 5 fraction schedule remained within 3.6%, so a 1.6% increase. So here are the baseline characteristics of the patients who went into fast forward. So the median age, I think, is no surprise, but we had a good old range of ages reflecting our practice. The majority of patients were treated with breast conservation surgery. Most patients were of grade 1 to 2, but there was a good cohort of higher grade patients in there. The majority, of course, were node negative, and the vast majority of patients were ER positive and HER2 negative. And about a quarter of patients had a tumour bed boost according to those pre-specified schedules. And you can see at the bottom there that the majority of UK centres at that time were opting for that 10 Gray in 5 fraction boost. Here's a little bit more detail on the surgical details. So I've already hinted that it was a smaller proportion of patients that underwent mastectomy, but this is just to highlight that the proportion of women that had reconstructions was really very small in this study, and that's of course caused a lot of discussion nationally and internationally, and in particular the numbers of patients having either autologous or implant-based reconstruction was very small. And I see that in fact in your data set you had 26 patients with reconstruction, so you're already trumping this data set with your numbers, and it'll be really interesting to see your outcomes. In terms of axillary surgery, majority of patients had some kind of sentinel lymph node biopsy or a guided axillary sample, and of course that can mean quite a few things according to the surgeons that you're working with, and then around 15% of patients had a full axillary clearance. The median pathological tumour size in this study was under 2 centimetres, reflecting that the majority of patients were recruited from the T1B to T2 population. Very small numbers of patients had neoadjuvant chemotherapy, really reflecting that this was a predominantly ER-positive, HER2-negative population. And around a quarter of patients had adjuvant therapies according to recommended UK schedules. And it won't be a surprise to you that the majority of patients given that background, so of the ER-positive patients, over 95% of them had adjuvant endocrine therapy. So we're going to come first to the oncological outcome data. So this is local relapse. There were 4,096 patients eligible for evaluation. As I say, the cumulative number of events was assessed at a median follow-up of 6 years. So they've estimated the cumulative incidence at 5 years. And I think what you can see clearly here amongst the numbers is that the 5 fraction schedules are certainly not inferior to the 40 grey schedule, and we've got overlapping confidence intervals. And what was nice about this study was that the upfront estimate of local recurrence was about bang on, which of course for many studies going in breast radiotherapy at the moment is not the case. We keep getting caught out with a lower than expected local control rate, but they were spot on, and you can see the 5 fraction regimens not inferior, and that's shown graphically on this slide, where the 27 grey is the green and the 26 is the blue, and you can see that they're certainly no higher than the red line. In terms of local regional relapse, again, the 5 fraction regimens are certainly not inferior to the 40 grey regimen. And then coming on to distant relapse and any breast cancer related event, again, you can see that these ballpark figures are A, low, and B, very similar to each other. And that's shown on the next 3 slides. We certainly can't get a laser pointer between any of those curves. So equivalent disease-free survival, equivalent cumulative risk of any breast cancer related event, and overall survival. Those lines are completely overlapping. Just to drill down a little bit into local relapse. So I think centres on the case report forms were asked to specify whether they thought something was a local relapse or a new primary. And of course, that's very subjective and really could only be determined according to location of the recurrence. There is a separate piece of work that's going on in relation to the import studies to look at genetic and pathological similarity between recurrences and original primaries, and that work will almost certainly be extended into the FAST-4 data set. In terms of contralateral breast cancer risk, pretty much as expected and equivalent across the arms. And then in terms of non-breast cancer deaths, what is obviously very reassuring is that as yet at this 5-year, so quite early time point, no difference in cardiac deaths across the 3 arms. So here's the first of a couple of radiobiological slides, and I put my hand up and say I'm not a radiobiologist, but I have a sort of lay understanding of alpha betas. And of course, if you plug in an alpha beta ratio of about 3.7 Gray that's been coming out from the series of fractionation studies so far, it will look as though 26 Gray and 5 fractions is a bit cool on the breast, but of course that does not take account overall treatment time, and it certainly seems that hitting these cancer cells harder and faster seems to make up for that lower dose. So now coming on to toxicity results. So the acute toxicity data was actually published almost 5 years ago. And I don't know how you find your 5 fraction experience sort of early on, but we certainly have observed, consistent with these data, that women having these 5-day schedules have a little bit less in the way of skin redness. The skin redness peaks around 2 to 3 weeks post the 1-week schedule, and it tends to be a little bit milder than for the 3-week schedule, according to this data, and certainly according to my clinical experience. Now, the late side effects were assessed in 3 ways: by the clinicians using a 4-point scale, by patients using a similar 4-point scale, and then by panel assessment of photographs using this 3-point scale. And I'll run through each of these in turn. So for the clinician assessed late normal tissue effects, for the first time, we're seeing a significant result here. So it certainly seems as though there were more moderate or marked clinician reported events in the 27 Gray arm, whereas the 40 Gray and the 26 Gray arms look to be pretty much equivalent, and no statistical difference there. And just to point out, we had nearly 4,000 patients available for this evaluation. So just breaking that down into different later effects, I think what you can see, broadly speaking, is that the 27 Gray arm has a little bit more pink in it. So more of these moderate or severe clinician reported effects in the 27 Gray arm, but pretty much equivalence between the 40 Gray and the 26 Gray arms, regardless of the endpoint. And very little in the way of telangiectasia, edema, and discomfort. Now, what you can immediately see with the patient assessments, and there are far fewer evaluable patients for this, because not all patients agree to these patient questionnaires. But first of all, the highlight is that the patients obviously report much more than clinicians do. So it seems that they are much more sensitive, but in our analyses of other similar studies, we see that clinicians and patients are equally able to discern differences in fractionation, but just the patients will report more. So again, I think you can see that the 40 Gray and 26 Gray columns, generally speaking, look more similar to each other, but there is definitely more going on in that 27 Gray arm, particularly in relation to breast appearance change and also firmness and hardness. Less or fewer problems in terms of pain, sensitivities, skin changes, but again, the 27 Gray arm, actually it's not quite so obvious on here, but it tends to come out a little bit worse. Here's where you can see clinicians and patients up against each other. So this really shows quite starkly how clinicians often miss the more subtle changes that the patients certainly notice in their own bodies. But the clinicians and the patients are consistent in their view that the 27 Gray regimen is hotter than the other two. So then we come on to the clincher in terms of which is hotter, which is the photographic breast appearance. And this slide is from John Yarnold and shows very nicely a patient on the left who we would be grading as having no change, and then a patient on the right in whom we would be scoring them as marked change in breast appearance. And here's where you can really clearly see that the 27 Gray arm is associated with more mild and marked change than the other two arms. And these changes appear to be progressive, as you would expect at the 5-year time point compared to the 2. So if we put together these sort of clinician, patient and photographic estimates of alpha beta, we come up with something in the range of 2 gray. And if we put that into this table, then you can see that the 27 gray and 5 fraction regimen comes out as being about equivalent to the old 50 and 25. Whereas the 26 gray and 5 fraction regimen is looking pretty similar to the 40 and 15. Just to pick up on another couple of things that people often ask about. So rib fracture rates were low and equivalent between the studies. Lung fibrosis is, of course, usually only picked up if someone has a scan for some other reason. The symptomatic lung fibrosis rates would be absolutely minute. And as I say, ischemic heart disease, low and equivalent between the groups. So the conclusion of the study is that the 5 fraction schedules are non-inferior to the 15 fraction schedule for local tumour control, but for late effects, 26 gray and 5 fractions is looking most similar to 40 gray and 15. And obviously implementation of these findings could potentially be of huge benefit to patients and indeed to healthcare systems with considerable cost savings across the board. So just going to run through quickly a couple of impact slides. So obviously all of these data were cooking around the time that the pandemic hit, and this was due to be presented as a late breaking abstract at ESTRO 2020, which of course got postponed. Obviously consistent with what was happening in Egypt, our cases were rapidly rising and we went into lockdown, I think on the 23rd of March 2020. So as I said earlier, the preparation of the final manuscript was accelerated. But in the meantime, I spent most of the weekends in March on calls with colleagues internationally, trying to agree some interim guidelines that we could all sign up to really sort of keep our departments going. Because I remember on about the 11th of March, I was asked which of my patients I wanted to carry on treating and which I was going to postpone to after the pandemic. And I felt there wouldn't be an after the pandemic for some time, so was quite keen to have an alternative solution. And we'd in fact been, big recruiters to fast forward. Obviously, it helps that I'd already seen the abstract, so it's a little bit easier to inform guidelines when you know the results of the study. But we had to have a sort of confidential discussion, pretending we didn't know the results, but based on our clinical practices and the balancing of benefits versus risks of delaying patients versus giving them this 5 fraction regimen. And we basically all agreed that it was reasonable in the context of a pandemic to, ahead of the Lancet publication, deliver 5 fractions over 1 week for these patients, or to use the published data from the FAST trial as you were already doing. And initially we applied this just to whole breast, chest wall and partial breast patients, but we did develop some simultaneous guidelines under Royal College of Radiologists auspices, which allowed us to give 5 fractions in the context of nodal radiotherapy as well. So how durable were the changes in practice? Well, a survey was undertaken as part of, again, some Royal College of Radiologists work leading up to a consensus meeting later in the year, once the heat of the pandemic had temporarily passed. So this survey went out to UK radiotherapy centres, of whom about 2/3 responded, to say that the majority of places were not giving this 26 gray and 5 fraction schedule before the pandemic, except a few in exceptional circumstances. And I was one of those. So we were treating a few more elderly, frail patients with travel considerations with the 5 fraction regimen. But during the pandemic, it'll be no surprise to any of you that all of the responding centres said they were using this 26 gray and 5 fraction schedule. And here are our data from our radiotherapy data set, which is a national data set, just showing that tick up in the use of the fast forward regimen post lockdown. And that was pretty much maintained even when we came out of lockdown number 1 in June. So post-pandemic, people were asked what they thought their practice would be, and the majority agreed that they would continue using this schedule. There was a bit more reluctance in the partial breast setting, but we unpacked that a little bit, and it transpired that there were a few people that were just nervous with the use of partial breast radiotherapy in general, rather than being nervous about the use of fractionation in that setting. And so we've got another piece of work, some training modules going out later this year to help support people implement the Import Low trial, which of course has been in print for 4 years now. But what we went on to do was to put some consensus statements to a meeting. So this involved a representative from, I think, nearly all of the UK radiotherapy centres. And these statements were sent out ahead, and people were encouraged to debate and discuss amongst their teams and come back with one representative who could vote on behalf of the local radiotherapy teams. And just to show you the results, so we've got a consensus process that we use across all RCR consensus meetings, and you can see that there was strong support for the use of the 26 gray and 5 fraction over 1 week regimen in the whole and chest wall radiotherapy settings. There was a little bit more discussion, as I mentioned, around the reconstruction setting. So people felt they wanted the option to be able to give 40 gray and 15 fractions in that setting. So to sort of open it up to individual patient by patient discussion. But for the partial breast radiotherapy setting, once we'd unpacked those technical issues, there was strong support there as well. And of course, strong support for that weekly regimen as well, because there are patients who prefer to do that once a week schedule rather than come up every day for a week. We had some other discussions about nodal radiotherapy. Now, the Fast Forward nodal study, so that's exactly the same design as Fast Forward, but includes nodal patients. That study is due to be analysed later this year. It would have been around now, but everything's been shunted back. So it'll probably be towards the end of this year now. And that will inform practice for this particular group. But we've agreed we should use 15 fractions over 3 weeks, unless there are significant comorbidities to consider. And certainly during the more recent wave of the pandemic, for older, frailer patients, we were using 5 fractions for a few of those patients, obviously following careful discussion and consent. And then, similar to you, we've come up with 2 different ways to approach the boost. So we either do 26 gray and 5 fractions followed by a sequential boost, and the majority of us who used to use 16 gray and 8 now use a hypofractionated equivalent. So in my practice, I use 13.35 in 5 over 1 week. Now, some critics might say, well, okay, you have not evaluated 26 in gray, 26 in 5 followed by that particular boost schedule. I think it's very unlikely that 13.35 in 5 is going to behave any differently to 16 and 8. So I personally feel comfortable with it, but we did agree that it was entirely reasonable to use a 15 fraction SIB regimen, exactly as you do. So our current patient pathway is that, so we were doing a lot of phone consent during the pandemic, but we're now back to face-to-face consent for the majority. We've produced a little video which just helps to support our service and helps patient preparation prior to those consultations. That's been really useful, again, during the pandemic. We have a one-stop consent to radiotherapy, endocrine discussion, DEXA check, and then patients go directly to what we call open access follow-up thereafter. So in fact, we do very little radiotherapy follow-up now, but patients get a pro forma at the end to support them through their skincare regimen. And our radiotherapy planning, of course, is pretty much unchanged, and patients, of course, get breath hold if they're left-sided. And of course, the beauty of changing fractionation is that you don't need to change any of your kit. But of course, the treatment slots are very slightly longer due to the longer treatment time and due to the verification schedules. Our radiotherapy planning dose constraints I've just popped up there for information. And are all, I think, in the supplementary materials of the Fast Forward publication, so you can see them in detail there. But just in final conclusion, I hope The 26 gray and 5 fraction over 1 week schedule is here to stay. It's certainly not inferior for local control. It looks equivalent to 40 and 15 for late toxicity. Huge benefits to patients and healthcare systems. And there's, of course, more data to come in the nodal radiotherapy setting. Just to acknowledge the huge amount of work that's gone into these data. I am a mere trial management group member on this study, so I can't take credit for any of this work, but it's been really exciting to work with the team on this. And that's the end of the presentation.
Thank you very much, Dr. Anna. Very informative, and I really enjoyed the work. And actually even enjoyed the extension of the presentation with your measures in the COVID and how we were dealing, because we had a lot of questions. We want really to share experience about that. I think you answered some of our questions, just some, because we have a lot of questions for you. But actually, we are ready now to start questions. For all the attendees, you can just send your questions in the question and answers section, or even in the chat section. But before that, I might start with one of my questions. Actually, I'm curious about that because I was asking this question for many of my friends in different countries. It's like when you get a patient who's tested positive during the course of radiation, how you manage that? Because we have this fight with the infection control team, and we don't want to, especially for sure if the patient is asymptomatic. I mean that if she's asymptomatic, would you consider a shorter gap? How do you manage, or how do you manage according to your practice?
Yeah, so in the first wave, amazingly, the situation did not come up, which was incredibly lucky. But in this more recent wave, we did have a lot of patients actually testing positive asymptomatically, because there are many more tests available. And what we did at the Marsden in Sutton was that we had a separate LINAC through which any COVID positive patient could go. So yes, at one point I thought, oh my goodness, what are we going to do with all these gaps? But we just kept treating them, and obviously there were very rigorous in between patient cleaning going on that particular machine, but it did mean that we could maintain their treatment. I have another practice elsewhere where they've only got one LINAC. So clearly that was not a possibility for them. And fortunately, again, the patients who tested positive all tested positive prior to starting. So we had some discussions about delays, and for a couple of my patients, we had 2-week delays. I think one patient ended up as an inpatient, so had a slightly longer one, but we were able to wait. Now, I have been party to some very complicated international discussions about people that have got to the end of 13 fractions out of a 15 fraction schedule, and then have been hospitalized for 2 weeks, what to do about the end. There's been, yes, enormous discussion, and in most cases where patients have got nearly to the end, the conclusion has been just that they've probably had enough to get rid of a low risk cancer. Fortunately, haven't had anyone with a higher risk disease where of course it would become far more complicated. So that's a big old fudge to saying I never had to tackle the problem personally, and we've been very lucky.
Actually, I'm happy with that, because it's it depends upon the practice. Actually, there is no rules, no consensus. I believe in that. It depends upon the experience, and no one had a longer than 1 year experience. We all are suffering from that, just starting from the last year. But I'm happy with your answer, because I'm always doing with the same with my department, because I don't have the luxury of having a LINAC for COVID patients. But whenever the patient is asymptomatic, we are just designing like the last 2 hours in the day. We are treating those patients with extra caution regarding the safety of the staff and the patients, to avoid cross infection. So we're almost doing the same. Yeah.
Okay. But just one other point is that obviously that sort of discussion did come into the consent, and so where I had a patient that might have been borderline between treating them using a 3-week regimen or a 1-week regimen, of course, we did have the discussion that a 1-week regimen is, in a sense, more, in theory, more resilient to gaps because you've got a longer overall treatment time to play with. So in our sort of upfront discussions, we're like, well, as long as we stick within a 5-week overall treatment time, we should be fine. And of course, with a 1-week regimen, you've got a bit more time to play with. So on that basis, I think that's how one, it's not persuaded, but many patients elected to have that 1-week schedule because of, just in case they got nobbled with COVID during their treatment.
Yeah, that's so clear. Okay, we're having a question from one of our attendees. The question is, why does the boost have to be in multiple fractions? Why not similar to the FAST trial where the boost is indicated, or if it's indicated, it's given just in one fraction?
Was that in FAST, or was that in
the FAST, the boost, when the boost is indicated, the boost was given like after 1 week, like it's like the sixth fraction when there is a boost.
Okay. Yeah. So yeah, no, that's interesting. So I have a palliative schedule that I use, which is 30 gray and 5 fractions to the whole breast, and then I home in on the usually sadly a fungating cancer with a smaller 6th fraction. So the answer to why we don't use it generally is that I guess we feel that we need more data to support that. It's certainly a hot topic for discussion, and it's certainly something that we're thinking about in designing what will follow on from the fast forward study. So I think where we're feeling there's going to be a gap is in firstly 5 fraction regimens for higher risk patients. So no one's been brave enough to treat IMC in 5 fractions except for us during the pandemic. I didn't put that in the presentation, but we treated 12 patients with 5 fractions to the IMC, and actually it's very easy to meet the constraints, but I guess the bigger issue is concern over whether 26 in 5 is hot enough for those triple negative, heavily node positive patients. But the other thing, obviously, we want to look at is delivering a simultaneous integrated boost in the 5 fraction setting. So we're trying to come up with a design of study that will tackle both of those. I know that there are people particularly using intraoperative radiotherapy that are, of course, keen on the 1 fraction approach and maybe even giving the boost up front before the whole breast. Obviously, you have to pick your fraction size really carefully. So, of course, if I'm giving a 6 gray boost to a large fungating cancer, I'm expecting that woman, even if I'm lucky enough to locally control her, will have a very indurated bit of breast tissue. Whereas for the majority of our adjuvant population, we've got these late toxicities down to such low levels, we're nervous about doing anything that's going to up their induration or shrinkage risk. So the answer is it's probably doable, but the discussions about which fraction size to pick would run to several pages, I think.
Yeah, so clear. Okay, actually, one of our physicists actually asked me to ask you this question. It's about actually, there are 2 questions, but I'm gonna start with the first one about the bolus. When we are treating in general our practice, while we were using the hypofractionation, the standard hypofractionation, 15 fractions, we were using the bolus just half of the treatment, half of the session, not all of the session. When we're using it for 15 fraction, we're getting really severe reaction. But with the FAST trial, actually, we excluded those patients to make sure that we're not going to get any severe reaction. Do you have any experience with using the bolus for the chest wall with such a high dose per fraction?
Yes, so we do use bolus generally only for inflammatory cancers or where the anterior margin is involved, but occasionally for dosimetric reasons if a patient's got a very, very thin skin over their chest wall. Now, in theory, and just to say, we don't do the half and half. So We used to do a centimetre of bolus for half of it and then no bolus for the second half. But we then did a little dosimetry study, and we now use, if we're going to bolus, we use 5 millimetres of bolus, but we use it for the whole treatment course. So we do that for our 15 fraction patients, and we also do it for our 5 fraction patients. And I mean, obviously it's quite a small number of patients, and this is anecdotal experience, but I don't feel that the acute or late effects are any worse for the 5 fraction schedule than they would be for the 14, 15. I think that matches the late toxicity data. So the fact that telangiectasia were very similar between the 2 regimens. I was going to say something else there, but it's completely gone out of my head. Oh yes, that the acute toxicity is less for the 26 in 5. So if anything, I would expect the 5 fraction regimen to be slightly gentler on skin acutely. So no, we haven't. It's not something that's worried us.
Okay, and the other question, our fastest question, is about the treatment verification, because we were having this debate while we were designing our protocol. It's about should you, is it preferred to use just a normal EPID or a COM-beam CT during each fraction? They were considering COM-beam because between fractions they are worried about some breast edema, for example. They were recommending that, but we didn't have a clear consensus. So we were curious about your practice about that.
I think the answer is we've tried both. Yeah, so we had a very efficient radiographer come in and switch us to cone beam for every fraction. I think we've sort of stepped back from that. We didn't see much in the way of swelling post fraction 1 when we were using the daily cone beam. So I think that's quite a rare issue, but of course it will depend on the timing of the radiotherapy in relation to the surgery and perhaps in relation to local surgical practices. So I think the answer is you can use either, but for a 5 fraction regimen, yes, we're certainly looking every day at how they set up. I just wanted to come back to the first question about bolus. Because I just remembered, of course, the 28.5 in 5 over 1 week is equivalent to 50 in 25. So, of course, it is, in theory, that's a hotter regimen than the 26 in 5 daily. So you might see acute effects that are similar to 50 and 25 with that regimen.
Okay, well, we have more questions, so I'm going to go through them. Yes, Dr. Radwa, I can hear you.
Yes, thanks, Dr. Anna, for your elegant presentation. I want to ask you, when you are doing acceptance for a plan, you mentioned to us that you kept the ipsilateral lung and port as lower as much as possible. But do you have restriction to the criteria that the V30 must be between 15 and 25, as we have the issue not to increase the fields or the tanges or the segments on the planning system to not to increase the time on the machine. So what about if a slight increase in the V30 or V15? I want you to share your experience for acceptance of then, as it's a very important issue for us.
So, Radu, I'm not quite sure that I'm totally following your question, but I mean, you're right. We generally try and keep the lung dose as low as we can whilst covering the breast or chest wall. We don't artificially accept more lung in order to achieve other things, but I'm trying to think, how can I best answer this? I mean, it used to be the case that if the lung depth on tangents was anything more than 2 centimeters, our radiographers would get very twitchy about that. And of course, 2 centimeters lung depth can relate to a whole range of different lung percentages according to the shape and the size of the patient. And then because we've been doing so much IMC radiotherapy and seeing no pneumonitis at all, we've become quite relaxed about that depth. So if whenever, some of the junior radiographers will come and say, oh, worried about the lung depth, what should we I always say prioritize coverage. Coverage is always, if you're going to treat something, you've got to cover it properly, just because the lung risk will be very low. Obviously, when you then add in nodes, occasionally you start to get close to the lung constraint. And so we've had a whole run of right-sided patients, for example, where we've decided to treat them in breath hold. And in fact, last week we just said, this is ridiculous. We're rescanning so many of these women. Let's just have an agreement that we're going to do right-sided. This is for IMC, obviously. Right-sided IMCs will all be treated in breath hold. I'm not sure that really answers your question, but...
Yeah, actually, I think this is an excellent answer, because I will clarify what Fred was mean. She meant that when we're doing the acceptance for the plan, sometimes we're having some small problem with low doses, when with the load like the V5, for example, and sometimes we just, we even accept with a bit higher than our constraints with the low doses. Then this is what she meant, that if you followed her slide, many patients just went out of the study because they didn't met the criteria of the constraints, and we're upset about that. That's why sometimes, but they're getting back to me to approve crossing a bit, just a few percentage of the low doses, and sometimes we do that, but we feel a bit guilty if this could be harmful. But actually, so far we're not doing that much, but it's going fine so far.
Great.
Okay, and we're having a question from Dr. Sarah Sharif. She's one of our specialists. Thank you, Dr. Anna, for your very useful, informative presentation. I have a question. Is there a cutoff value for volume of breast that we can irradiate safely with fast protocol with less side effects? As I think the large breast volume was a factor that might contributed in the outcome of the case that Dr. Wader presented.
Yes. So the answer to that is that, yes, we know that larger breasted women will come off worse from radiotherapy than their smaller breasted counterparts. But there's no reason to suppose, based on the fast forward or the fast data, that by giving them a larger fraction size, they will do worse just because of the fraction size. So as long as the fraction size you've picked has been shown in a study to be equivalent, then we do not exclude that. We have no cutoff for breast size. So a patient of any shape or size, we would treat with the 26 gray and 5 fraction regimen.
Okay, another question from Dr. Islam al-Mosri. He's asking about, is it safe to use the DIBH technique with ABC in the era of the pandemic? I'm not sure if you're treating using the ABC or just using the RPM like we had. But yeah, this is an interesting question.
So we in fact we use a voluntary breath hold technique. So patients just take a breath in and hold it. So that's just perfect for a pandemic. I know that there are some concerns about ABC, and I think in our lung practice during the first wave, the use of the ABC device was paused due to infection control issues. Now, I think they have been using it during this more recent wave, which suggests to me that they've got round that. I'm sorry, I can't tell you how they've been able to justify it this time and not last time. I can see where you're coming from, but obviously they've run it past the powers that be, and it's been approved. We have single-use mouthpieces, so 15 fractions equals 15 mouthpieces. But I know that some people say kind of the virus can hide in the tubing of the instrument. I don't know, but again, we were a bit lucky that we use you've got the RPM and we've got VBH, so we're fine. But yes, some people aren't.
Okay, this is an interesting question. A managerial question, a financial question. Actually, how do you arrange for financial billing for the 1 week versus 5-week protocol for insurance issue?
Yeah, this is a massive. So as it happens in the National Health Service, we're sort of moving to block contracts. So our department is paid to deliver radiotherapy for our population, and then it's up to us how we deliver that. So actually then by delivering it in 5 fractions versus 15, we're using our pot of money more efficiently. But internationally, that it's absolutely huge. And I can tell you also in terms of private practice as well in the UK that because insurers reimburse by fraction, there are some businesses that will no longer be able to function because breast fractionation has changed. I think that's a shame, and obviously there have been many technical improvements in radiotherapy over the years. So to me, a woman's getting is still a high quality treatment, and we should have been cleverer about our negotiating and bought it as a package of treatment. That's so. I mean, in general, the response is that that's the way that discussions are going in the UK, and I think internationally is that we pay by package of care rather than by fraction. But it doesn't leave some people without a big hole in their finances in the meantime.
Yeah, exactly. Okay, actually, I have a last question because actually we're supposed to be at the end of our webinar, and I know you are super busy, so I don't want to take much extra time of yours. So it's like a question to wrap up the presentation and the experience we shared with you. So far we are planning to conduct a fast forward protocol, or to design. Actually, it's not even a conduct. We're the phase of designing the protocol. We're still having a limited experience, as I mentioned, with the fast protocol over 5 weeks, but actually the 26 grays over 1 week is really encouraging, and there is enough safety data for us to conduct our own or to treat our own patient doing that, especially that I know you know that because I told you before that many of our patients are like not a Cairo residents, so they come from another cities, so they're like booking some hostel or hotel for the treatment, or sometimes it's difficult for them to stay for much longer time, or to travel for 5 weeks with 5 long journeys. So I'm really interested about conducting that, and I really need your advice. Like a general advice, you should expect, a lot of consultations in the upcoming few months. But for now, just it's like a general advice or recommendation if we should proceed with that, and how this should go.
I mean, I would absolutely think you should go for it. I mean, for the reasons that you've mentioned, for convenience for patients. I mean, it's very, very few patients that say to us, "Oh, we can't possibly come on a daily basis." It's it's particularly for people who are traveling a distance. Actually, to just consolidate it all in 1 week is great. Secondly, of course, back to the point I made earlier, 26 in 5 over a week looks to be equivalent to 14, 15, whereas the 28.5 in 5 is 50 and 25. So just in terms of having a slightly cooler regimen, I think that's it would be the way that I would want to go in my practice. And then I think where your data set for the fast regimen is really going to add value is in the real world. Particularly with changes in oncoplastic techniques, with multiple different ways to reconstruct the breast, and now our surgeons are doing all sorts of different flaps in from everywhere else. To have a real world data set evaluating outcomes using this regimen will be so value added to the international community. So absolutely encourage you to go for it.
Actually, so far as I know, I don't believe there is any trial which is comparing the fast and the fast forward. So far, I never heard about anyone who comparing the post regimens. I was thinking about doing that. If it's feasible, might be something interesting for a design.
So then it'll just come down to what your primary endpoint is and how many patients you need. I'm smiling because I'm having a very similar discussion with some surgical colleagues about a pre versus post reconstruction radiotherapy study, and it's so easy to head into the thousands if you pick a local control endpoint. If you go for something toxicity, hopefully you'll have a shorter study, but with fewer patients. But there's still such huge numbers because we've done so well, haven't we, in breast radiotherapy? The very few patients recur, and very few of them, fortunately, look like the case that you presented earlier. So we have to get these big numbers. So yeah, we were having a very frank discussion about whether the era of the randomized controlled trial might be over, and actually we're just all best off doing registry studies and collecting as much data as we can. But I don't want to rain on your parade. I think it's definitely worth thinking it through.
Yeah, exactly. Okay, actually, unfortunately, our time is up. It's sad for me, actually, to announce that. But actually, this is not going to be the last event. We're going to arrange something for sure very soon. Dr. Anna, it was really great pleasure to have you. We were honored to have you with us today. Can't thank you enough for your presentation and for all of this information you shared with us. And I'm sure we're going to meet you soon in Cairo in person after this pandemic, and make sure that you're on the top of our invitation list in our upcoming events. Thank you very much.
Well, thanks so much for having me. It's been a real pleasure. Really nice to meet you.
Thank you. Thank you, Dr. Rodwell, for your presentation. And thank you all for our attendees. And hopefully you enjoyed our webinar. And we're going to meet soon, hopefully in another event. Thank you so much, all of you. Thank you. See you soon.
Bye, everybody.
Bye-bye.